Thank you, RIC, and thank you all of you for coming out in the morning. My talk is basically summarizing and kind of, bringing all the thoughts that were presented earlier in a kind of systematic way to be able to help us to, think about where we would consider therapy or not. Because right now, the main decision making in GA is whether to give therapy or not once it is available in India. It is available in the US, but right now, it's only available on shady sites in, online sites in India. It's not really available through through the official channels. So the million-dollar question is, in which eye will the fovea get involved in GA? And that answers the question where we would be, aiming to give this therapy. So now the assessment of geographic atrophy has already been presented. Color fundus photography is a very primordial way of doing it. Fundus photography is better because it is unfast, makes your recognition easier. Easy area management is there, but you cannot get cross-sectional information. For that, the structural OCT is better, and quantification is also better with structural OCT, and it is universally available. Now, how do you characterize geographic atrophy? You look at the lesion characteristics, that is the existing GA. You look at the size, the multifocality, and the location, how far away, what is its eccentricity from the foveal center. You look at the junctional zone properties. Now, junctional zone is the most important area to look at when you're looking at geographic atrophy cases, because this is the advancing margin of the geographic atrophy. So you look at the AF pattern, and has already been earlier mentioned, the banded pattern and the diffuse trickling type are the ones that have the maximum rate of progression and involvement of the fovea. You look at intraretinal high reflective foci in the junctional margin. These are also very, very strong predictors of progression to GA. The outer retinal thickness and the photoreceptor thickness I will allude to in a short while. And thin DLS, we've had an extensive discussion, which probably represents the B-lam-D or the laminar deposits above the Brooks membrane, which cause the atrophy of the RPE. Now, drusen volume and a hyperreflective drusen core are also important predictors of GA. Of course, this has more meaning when you look at it locally. So the local growth analysis, the local margin of the GA, how it is growing, that gives you far more important information as to whether you want to treat or not. Now, several features have already been described, but I will just point again at the important features. That is one, the drusen volume. Second number is IHRF presence. Look at the odds ratio. It is way above the, 1 mark. So these are independent predictors of progression to GA. A thin double layer sign is again a very important predictor. And of course, geographic atrophy involving the fovea in the other eye is also a very strong marker for progression of geographic atrophy involving the fovea. So this is a study which looked at the 2-year progression rate, and what they found was a lesion that is closer to the fovea, a lesion which has a thin DLS sign in the junctional zone of the GA, and of course the reduced oral thickness. These are all signs which tell you that the progression to GA, foveal involvement in GA is highly likely. And this is the DLS sign again brought out. The presence of a reticular pseudodrusen or the SDD is not very important, and so is not the multifocality of the lesion. Now, why are local indices important? Because global metrics do not really present, convey the information about the threat to the fovea, and that is why local progression rates are important. Now, incorporating the local growth rate of the GA margin towards the fovea, along with the features of the junctional zone, is going to give you a lot more information as to how this lesion is going to behave. And for that, an AI model is necessary, because there are lots of things that you have to calculate. So this is a paper which presented this kind of analysis where they marked the GA margins, and of course, on follow-up, the scans were superimposed, and the local progression rate at multiple points along the GA and their direction of movement, whether it is going towards or away from the fovea, was calculated. The local rates in the lesion, they were color-coded to show how fast or how slow the progression was. Also, the photoreceptor thickness was marked topographically on the map, and of course, the HRF concentration. So this kind of composite data gave you a very, very accurate, I would say, a picture of what lies ahead and how this lesion is going to progress. Is it going to involve the fovea or not? And that makes your decision making easy. So if you think that the fovea is really threatened, then you go ahead and initiate therapy. Otherwise, you don't. So it's not like like looking into a crystal ball to find out whether this lesion is going to progress and involve the fovea or not. It is more like connecting multiple dots to see the larger picture. So to summarize, eyes with GA that are potential candidates for benefit with therapy, once it is available to us, is number one, proximity to the fovea, a thin DLS at the fovea, presence of intraretinal high reflective foci and a thin ORL in the junctional zone, and a contralateral geographic atrophy involving the fovea. These are the most important, I would say, take-home message that if you have this, then this candidate has to be informed that, once the therapy is available in India especially, we are going to, offer you this. And of course, specific AF pattern can also give you a hint of progression. Thank you so much.
Thank you so much, Abhishek. Very nice talk. I have to bring you on spot that if we are worried about drusen volume, and we know that if there is drusen regression, when the volume is coming down, and drusen regression is actually a more closer predictor for GA. How do we use this?
Yeah, absolutely. So this is not about the temporal trend of this thing. Whether when you have a, I'm talking about once the patient comes to you with a GA, and along with the GA in the area in and around the fovea, you have a larger amount of drusen. That is, the drusen volume is higher. You expect those drusen to collapse and have a GA there. So this is only about predicting whether it will, go ahead and have a geographic atrophy in that area. Since we are talking about when the patient comes to you, whether this at that particular moment, what exactly is the, I would say, the age or stage of the life of the drusen, it's very difficult to, say that in one go. But when on follow-up, if you're looking at higher drusen volume, and if you see, then of course there are hyperreflective foci, or there is intralesional, I would say, non-homogeneity, you would expect it to collapse and have a GA formation there.
Thanks, Abhishek. Adnan, I had a question for you because I know that you have been involved in a lot of AMD biomarker studies. So in your opinion, where do you weigh the drusen volume, which is not available to everybody? I know that Retina AI and Retina Insight are working on this. But the question here is that how does every machine can incorporate drusen volume as one of the predictors, while we have to take a 97 scan, which itself is a much more time-consuming in routine practice. So what do you want audience to focus on?
So you're saying from a practical point of view, what should we do now? Well, since we don't have any licensed therapy, just the simple observations, and I wouldn't quantify anything at this point, unless you want to develop your own internal natural history data set ready for when the drugs get licensed, and then showing that information to the patient may help you and the patient make the decision to go for an invasive therapy where their vision doesn't improve. So the only reason to do it is to characterize your own patients ready for the treatment.
I think this is really one of the best answers I have heard, because we know that the future is here, and in 5 years we are going to start treating these patients much earlier. So it is very important that we start establishing the data set.
Because otherwise, in a busy clinic, it's such a burden to do all of this, unless we've got brilliant software that automates everything, and they're all validated and cross-validated, which we're not quite there yet.
Yes, absolutely. Great. Thank you so much. Any other questions for Abhishek? No? Do you have mic work? Ramesh?
So how do you differentiate between a non-neovascular fluid in geographic atrophy versus a patient with macular MNV with geographic atrophy? Is there a difference in the pattern of the fluid which you develop, and how do you differentiate it, and would you treat it?
I wish I could just close my eyes and tell. Abhishek, do you want to answer this?
Pardon?
Do you want to answer this?
Yeah, sure. So your question is that whether it is a MNV-related fluid or whether it's a GA-related thing. So, of course, the first thing is that, on an octa or even on an angiogram, you will pick up your MNV. That is number one. Now, MNV can be associated with the geographic atrophy, but geographic atrophy per se is not the reason for your fluid. It's almost never the only cause of your fluid in the complete absence of a neovascular process. So if you're not picking up a network, then I don't think that I would blame the GA for the fluid.
So every fluid in a GA patient is because of macular neovascularization?
No, it depends upon the location also, of course. It will depend upon the location where it is. And if you have, if the case that you are alluding to is the occurrence of the GA along with the MNV, now that is a different story altogether.
You have to look at other surrogate features like we discussed earlier, DLS and HRF and other things. So there are a lot of factors which will let us know that whether there is an active MNV or it is not.
So the reason why I'm asking is that there have been cases where I've seen intraretinal fluid just accumulating overlying the geographic area. Okay, and that has nothing, there is no associated MNV in those cases. So is that kind of a pattern which is obviously seen, because that's what happens, because you have depletion of Muller cells, RP, so the absorption of the fluid which is supposed to happen by the RP is not happening. And therefore you have that fluid accumulation happening in the intraretinal layers.
At that stage, we will have to differentiate from the pseudocyst as well as understand whether there is an RP breach or a case which Pradeep showed where there was a restart or a starting of a CNV.
Or it could be ORTs.
Or it could be an ORT.
That is a little too presumptuous. I think everyone would be able to differentiate an ORT from a intraretinal cyst, so I won't go to that extent. But the question which is more relevant, and it is true that you get this sometimes, I think I would take the default position that it's an MNV. And if it responds to an anti-VEGF agent, well and good. If it doesn't, then you know it's more likely to be related to the
trial of anti-VEGF.
Yeah.
Ritesh, I don't want to say no to you. Please go ahead.
Thanks, Jay. So I'm coming on to this from 2 points. One, Abhishek also mentioned it, Dr. Talwar also mentioned it. We are talking about GA in patients who have fovea spared, and we are talking about foveal extension, keeping in mind the drugs and the 6/6 vision, and we are trying to preserve it. But the story is not just that alone. We are underemphasizing the importance of extrafoveal extension also. I've had patients with microperimetry fixations just at the border of GA, showing hypertransmission changes on autofluorescence, and it's really scary that he will be losing that fixation point also. So just to say that only foveal extension is what we should be worried about, I don't think that's a right narrative. It may be a right narrative when we think about the drugs coming and we are trying to preserve that. We are equally concerned about autofluorescence showing extension, more peripheral, and losing those fixation points on microperimetry. We should not...
That's really one of the emotional, I should say, concern as well, because these are the patients who are probably having some PRL through which they are still getting along with their life, but if that gets affected, that's a trouble, which I totally understand. Thank you so much, Ritesh. That was really a very good point.
I think Ritesh, is basically you try to preserve the fovea when it is there. Usually they have these eccentric points of fixation when the fovea is affected by something else. And in that case, you would always, the candidate for therapy would be the one whose fixation point is threatened, frankly.
Yeah, and the future therapies are coming up with the implant as well as gene therapy, also targeting towards extrafoveal. Thank you so much, Abhishek.